that is so that any folks who are not present with us today, colleagues that weren't able to make it on the plan side, and others can access the work group in the future. And so I see we have a pretty good number of folks here. So I'm going to go ahead and kick us off. And you can start. Oh, it is recording now. Okay. My name is Zach Hennessy. I'm the Chief Strategy Officer and Executive Vice President of the Whole U NYC Network here at Public Health Solutions. And I apologize if some of my opening remarks about who we are is redundant, but we do have a lot of new plan partners on the call today. So I want to be sure to say a little bit about who we are and how we got here. So Public Health Solutions vision is health equity in New York City. And we go about that in three primary ways. First, we're a longtime service provider providing critical public health services in the community across the 5 boroughs in the areas of maternal and child health, sexual and reproductive health, food and nutrition, access to benefits, smoke-free housing and communities. And so we have been, quote, addressing the social drivers of health, unquote, for many, many decades and bring that experience to the table in doing this work. Another way that we go about advancing health equity is through our contracting and management services. We develop contracts that work for healthcare and community partners in collaboration with government and philanthropy to ensure that dollars are reach where they're needed the most effectively and efficiently. And so we have worked as a contracting agency for many years and bring that experience, and we'll bring that experience to bear as we work in contracting with our downstream whole U NYC network partners. And then third, building on those two historic strengths, beginning in 2015, we began our healthcare community partnerships work, recognizing that there are many, many resources in the community that healthcare partners like managed care plans and healthcare systems can leverage on behalf of their patients and members, but don't have the administrative tools and capabilities in place to do so. We started our whole U NYC network journey. First with coordinated intake for maternal and child health home visiting in 2015, and then with our technology partner Unite Us in 2018, systematically connecting healthcare patients to food and nutrition resources. And then in 2020, expanding to the full range of social services across the city with over 400 community-based organizations offering over 800 services on the Unite Us platform through whole U NYC. So that was really the foundation for our application as a social care network. Those core strengths and then that work with our technology partners to formalize those strengths into a network that has been operating since 2018. And so we're very, very excited to be at this point as the social care network for Queens, Brooklyn, and Manhattan. And we know that we are implementing fast and furious here. Every day there is new information coming out from the state, new template contracts, and new policy And so we have formed these work groups. This is the managed care work group, but we also have a CBO work group and a healthcare screening partner work group so that we can collectively share information that we know and that we're learning, and have discussions as a group with our stakeholders instead of trying to uh, manage all of these conversations individually. And so with a deadline on the horizon of executing contracts with our managed care partners by October 16th, we felt like it was really important to bring everybody together, and to do a little bit of level setting, and discuss some key issues that I think we probably share between the SCN and managed care. All of this is to meet our shared goal, which is the seamless and effective delivery of resources to Medicaid beneficiaries that improve their health outcomes and reduce acute healthcare costs. Every year in New York, hundreds of thousands of people avoid healthcare due to concerns about putting food on the table, transportation, their housing situation, and other pressing family priorities. We've all done it. We've all put things in front of our health. And so the goal of Whole U NYC is simple. The goal is to make the resources that currently exist in the community more accessible to all New Yorkers and stand up these new resources that will be available through the Medicaid program in a way that is accessible, trustworthy, and reliable. So I think both you all MCOs on this call and us as a social care network can thoroughly embrace that shared goal. Next slide. So I want to touch a little bit on some of the key components of the agreement. And then I will turn it over to our technology partner to talk a little bit about the claims process, just to do a little bit of level setting and also provide some specific information about how we're approaching the work. And I'm sure you've all received this agreement. Many of you have sent it to us. So some of this may be repetitive, but I think it's important to go over together anyhow. So it's a legally binding document designed to ensure successful program implementation. And you can go to the next slide. And there's a role for us and a role for you. And so as a social care network, what we will do, it falls into three buckets. There is our network of providers providing screening, navigation, and the new services on the fee schedule. There is the navigation workforce piece and all the activity involved in supporting individual members to connect to those resources. And then there is data and information management. These roles are all outlined in the template agreement that the state has shared between SCNs and MCOs. So as a provider network, you can stay. As a provider network, it's our role to establish and manage the network of service providers across the various domains, housing, food, and transportation. We intend to do this according to very high cultural and linguistic standards, especially given the diversity of the region that we support. It's our job to monitor the network, identify gaps in resources, where people's needs are being met, where maybe they're not being met, and fill that capacity. And we have to maintain a directory of all of our service providers on our website as well as a publicly facing portal that allows people, anyone who comes to our website, to access resources. Our navigation role includes screening members annually for unmet needs using the Accountable Healthcare Community Screening Tool, determining their eligibility, using the Enhanced Services member file provided by MCOs for eligibility determinations, facilitate a member-centric screening process that is accessible, timely, and culturally appropriate, and providing ongoing navigation to support to members, including eligibility assessment, referral management, and care plan development. Now, what's unique about our approach to this is that we intend to leverage the navigation resources of our CBO partners to the greatest extent possible in doing this work. We, PHS, do not want to set, we will have a navigator as of last resort role, meaning we will make sure no one slips through the cracks. But given the large number of members and navigation that they will require, we don't intend to do all of this work on our own. We intend our CBO partners to do a lot of screening, a lot of navigation, and PHS's navigation workforce just acting as a navigator of last resort. And then on data and information management, it's our job to ensure accurate and timely submission of claims, and we'll dig into that a little bit with Unite Us today. Collaborate with you to make sure you have the data you need for the Core reporting to OHIP, and maintain compliance with all data privacy and security requirements that are outlined by the state. Next slide. What does the contract say about the MCO role? So member communications, it's the MCO's role to distribute notices to members with information about us as provided by OHIP. Update your handbooks with relevant SCN information using OHIP provided materials. With data, there's a big role for data sharing and collaboration. You are the ones who produce and submit the Enhanced Services member file to the Shiny Data Lake containing member eligibility details for the services, and collaborate with us to establish a communication workflow for eligibility changes and updates. Now, there's a lot still unknown about what the state will accept in terms of verification for eligibility changes. So I don't have all the answers there, but we are expecting a version 2 of the manual with greater detail on what will be accepted as sort of proof of eligibility changes from the SCN to the MCO. Also an MCO role, if you're choosing to use the data and IT platform, you have to designate employees for training and access. So we will have onboarding and training requirements for anyone who joins our data and IT platform, and that extends to any MCO who intends to use the platform for the purposes of screening and navigation. Although I do want to be clear, MCOs cannot be paid for screening and navigation. The state is allowing them, to screen and navigate, but not receive payment for it. And collaborate on additional data sharing to support performance improvement and evaluate effectiveness. This is a big call to action from us to you. We want to be sure that in our managed care partnerships, our data sharing enables you to really see the difference within your membership of members who received the enhanced services provided by the social care network. We think we have really high standards as it relates to how to do this screening, how to do this navigation, how to do it in a culturally and linguistically competent way. And we think that's going to create better access to these resources for members than the kinds of screening that's happening today as it relates to health-related social needs screening. But we need to work effectively with all of you if we're going to be able to prove that. So we have a lot of thoughts about what that evaluation could look like. And we hope that we can achieve some of that evaluation together with you. And then on payment and contracting, the role for the MCO is to process the claims submitted by us for the services provided to your members and distribute the PMPM payments to cover the cost of the screening and services. So I'll pause there just for a second to see if there's any, Relitza, have there been questions flowing in? Are there
questions thus far in the chat?
Okay. So in terms of data information management, and I do have a flow chart for you, but it's the state's vision that we leverage the Shiny for secure and efficient data sharing between us and the MCOs. And as of last week, I'm pleased to announce that we have selected Healthix as our regional QE to work with. And so we'll be doing some testing of this process in collaboration with the Shiny over the coming weeks. Streamlined eligibility verification. We will be receiving the enhanced services member file monthly to verify eligibility for enhanced services. And that eligibility will be accessible to those navigators who have that role in the system to be able to see if they're eligible for screening, and then secondarily, if they're eligible for enhanced services based on the file. And then on data privacy and security, we are committed to adhering to all the applicable state and federal regulations. It's a requirement that we meet the security provisions as described as moderate plus by OHIP. And we're working very closely with the Data Privacy and Security Bureau to review our current state, identify any gaps and the places we need to strengthen and bolster to be ready for implementation. And, I think we have two great tech partners as well as an external security expert vendor working with us to ensure that we're really strong in privacy and security. And then I want to be sure MCO folks are aware that I say our two primary data and IT systems, our data and IT platform, the referral platform that handles the screening, navigation, and services is Unite Us. And we are also working with Hyphen as a data warehousing and interoperability partner. The goal there is to be able to bring in other sources of data into a data warehouse that becomes a permanent piece of infrastructure for public health solutions and allows us to develop our value-based care capabilities as well as do more complex evaluation and have some performance enhanced claims data as well to be able to be more effective as a social care network. So both Unite Us and hyphen are high trust certified. And that is sort of a summary of data privacy and security. Next slide. Oh, we lost the presentation there. So here's just a visual. This is from the state, kind of how the enhanced service member file is anticipated to flow. This is probably familiar to all of you, but there's your enhanced services member file that goes to the Rochester Rio QE. They aggregate it, do some cleaning. Bear with me, I'm not a data person. Cleaning, compiling, synthesizing. That goes to the Shiny data lake, and the Shiny creates our region specific ESMF file. So ours, the one that will come to us, will have all of your files that pertain to your members who are currently residing in Queens, Brooklyn, and Manhattan. And that comes into our SCN platform via the QE, which we have selected as Healthix. So it goes from Healthix into Unite Us, where we can see if they're eligible for screening, if they've been screened, and if they're likely to be eligible for enhanced services as well. Next slide. So I think working with you all collaboratively will be critical for performance monitoring and evaluation. We'll work together to track key performance indicators, identify areas for improvement, and evaluate the effectiveness of the model. So I really kind of covered this before I got to the slide. But both Unite Us includes the key performance indicators that are required by the state. We have a sense of what those metrics are from the template reports that the state has provided to us, and Unite Us is rapidly trying to build those into their platform to ensure that we can provide all of the requirements. But it's really at its most distilled level, it's really about what does the referral cascade look like from the point of screening to enrollment and sustainability in services. And so we're going to be able to look at all these different access points for screening. Was the screening done by a CBO? Was it done by an MCO? Was it done by a health system? Was it done in our platform? Was it done through interoperability? And what does the performance look like with all those access points? Did the person self-refer through our website? And with our whole UNYC network, we've already been examining that referral cascade for years and looking at the various access points. So we know pathways that work and are trustworthy and reliable, and pathways that do not. And we're going to be applying that history and knowledge to how we look at performance and evaluation of our social care network going forward. And as I mentioned, we want to bring in other sources of data to our data warehouse to look at the extent to which we're meeting community need. What are we doing at the zip code level? Where are the gaps? And that data warehouse is key to being able to ingest all those additional sources of data to do that sophisticated performance monitoring and evaluation. Yeah, and I think we can go to the next slide. So now I'm going to turn it over, before I turn it over to Unite Us, let me see if there's any questions coming in the chat, or does anyone have any questions? All right, from Derek. Hi, Derek.
Hi, Zach.
Go ahead with your question out loud, Derek.
Yeah, it's a long one. So the latest final MCO SCN contract added language to 5.3 MCO consent policies. I think before the language was added, there were fewer concerns about the uh, requirement from the MCOs to obtain consent before sharing data. The additional language has us second guessing ourselves a little bit there. Where it's in bold, so I won't repeat it. But the concern is that a conservative interpretation could be that we are required to get new or separate consent from our members before being able to share the data with our SCN partners. I was just curious how PHS or any of our MCO counterparts have been thinking about that.
So it's not something, to be honest, it's not something that's was on our radar, Derek, and thank you for bringing it up. I'm, it wasn't our understanding that for the purposes of, and I assume what you're saying is for the purposes of even sharing this ESMF file, via the state's proposed pathway. Most of our understanding of the consent requirements have been so far is that there's a question 0 attached to the AHC screening tool that where in order to share screening information, the state is requiring that consent be obtained before the screening information flows through that pathway through the QEs and to the SCN. I hope that the consent data that they're referencing here really has to do with any screening that the MCO is intending to do and not related to the entire data on the ESMF file. But I will share this. I'm sure you've probably shared this, but we have our check-in tomorrow with our folks at OHIP, and we'll certainly share this concern with them.
Thanks, Zach. Yeah, we have a check-in with our DOH counterparts tomorrow as well, and we certainly plan on bringing this up. We don't suspect, we don't think that the state is trying to, torpedo this whole thing with this requirement. Obviously for Health First obtaining consent from 1.3 million members that are eligible for this waiver be a very difficult and big lift. But we certainly want clarification around this. And we had originally, Zach, the same kind of understanding as you, that the consent piece was actually mostly with the SCNs and the CBOs that are performing the screenings and providing the services. So this kind of threw us for a loop.
Well, Derek, anything that you, and this is true for anyone on this call, we have great lists in terms of who's working on this at each MCO, as well as our CBO list and our healthcare provider list. So if anyone on this call learns something that they feel should be shared with any of those stakeholders or audiences, we're happy to facilitate that communication. Of course, we would review whatever it was, and we would also have to agree that it was something that should be shared. But if you learn something, Derek, about this question, and now other MCOs are asking themselves about this question, we're happy to share anything you learn, as well as we'll share anything we learn with this group.
Sounds good. And will do. Thanks, Zach.
Hi, this is Tina Radovich from United Healthcare. I'm hopeful that I can just jump in really quickly and piggyback on that, Derek. One of the items that our legal counsel has flagged is the consideration of HIPAA's minimum necessary rule when data sharing. And really, when it comes into play, where the managed care organizations are required to share all Medicaid member data with the Shiny, and then, of course, that member data with the SCN lead entities. Even those members that we have not found to be eligible for those enhanced services. So this is something that United is considering and have posed to the DOH via HPA, but I did just want to call that out here. I'm not sure if any other managed care organizations have thought of this.
Yeah, Tina, we have, and part of that thinking, or questioning rather, is also whether or not SCN lead entities can or should or will be treated as providers. A little tricky, right? Because they're not providers of traditional healthcare services or covered services, but to the extent that waiver services are added to the Medicaid benefit, then can or should we be able to consider them providers? And does this question of minimally necessary data sharing, HIPAA rules, et cetera, kind of resolve itself a little bit if we are able to consider SCN lead entities as providers?
Yes, so we actually did share, Derek, that same question about provider versus, it's kind of sitting in a little bit of a provider vendor space in our opinion right now. So we're kind of in the same boat. So good to hear that we're not alone.
I can say that we were all, as SCNs, we were all required to establish the SCN provider type with an NPI number in the eMedNI systems. They have designated us as providers. Now, probably you're aware of that, and I don't know how that fits into things, but we did all complete that process, and the state has designated us as providers through these NPIs.
Right. No, we're definitely aware of that, Zach, and that's the conversation we're having with our legal folks and regulatory folks. But it kind of also goes back to, well, providers for us traditionally are healthcare providers, taking care of covered services, that sort of thing. But I suspect that, Zach, we're probably going down that path of SCN lead entities will be treated as providers. That's the hope.
Great. Well, we do have room at the end for additional discussion if this has percolated some thoughts and questions among others. So I will now turn to a little bit of a discussion of the claims implementation approach. Mark?
Thanks, Zach. Really appreciate everybody's time today, and thank you to Public Health Solutions for allowing some space for us to have this important part of discussion here. For those of you who don't know me, my name is Mark Natali. I am the New York State Director for Unite Us, and as Zach mentioned, Unite Us is the technology partner for Public Health Solutions as a social care network in 3 regions of New York, where we will be partnering very closely across the ecosystem. Also, Unite Us is an end-to-end technology that operates in pretty much every state across the country. We operate in many other 1115 waiver states. Many of you are familiar with North Carolina, for example. But we partner with thousands of government, healthcare, community-based organizations, agencies, institutions of all sizes to support whole person care. So when we talk about the ecosystem of the 1115 demonstration waiver, the relationship and collaboration here between the social care network and the MCOs is really vital, as Zach outlined. So what we wanted to do is take a few moments today and outline, give an overview of the claims approach that we'll be engaging in with each of you. And when I say with each of you, there is a little bit of follow-up homework, but it's important to make sure that we're connecting for the social care networks that PHS is operating under, and making sure that the implementation is smooth and the claims approach to get all of the 837 claims, $0 837 claims, all the information is really as seamless as possible. So with that introduction, I'd like to pass it over to my colleague, Zach Parker.
Hello there. Zach Parker here, Senior Manager on the Payments Data Integration team at Unite Us. I just want to do a little high level. We can actually go to the next slide. Just do a little high level of who we are and what our experience is. So along with me, I have Joseph Jablonski, who is a business analyst on the Payments Data Integration team. Another team member is on PTO, but she will be helping with this as well. Her name is Gracious Gumyao. We also have a couple other individuals who may be helping with things like SFTP connectivity. So you may see some other individuals pop into our meetings that we'll end up having about implementation. So as Mark mentioned, we have good experience with sending out 837 claims for other 1115 waivers. So this is what we do day to day. This is what my team specializes in, and specifically with payments. I'll talk again, but Joe is going to walk you through the process flow for the claims implementation.
Sure, great to be able to meet everybody here. If you pass to the next slide, that has our flow chart. So our process flow, it's a relatively simple one when it comes to the claims that are generated from invoices submitted in the referral platform from the actions taken with the SCN leads in partnership with the CBOs. When an invoice is submitted, it'll be put onto an 837 professional claim that gets generated on the Unitas side. We then deliver that claim either to an MCO directly or to a clearinghouse, or it is kind of picked up via hosted SFTP by the MCOs or clearinghouses. I want to call out here that we have here the clearinghouse swim lane for our claims process. You'll see that if a clearinghouse is involved, and again, it is simply that is an if applicable process, because we know not every MCO will probably be using a clearinghouse. Let me just give 1 second. We have the charts kind of disappeared, but I'll kind of talk about it as we're continuing. So when an 837 claim is sent, if a clearinghouse is involved, they will return a 999 response file, as well as a claim status file, also via SFTP. If the clearinghouse is not involved, we would just get back a 999 response file from the MCOs. This is simply the standard template of our workflow. We understand that there might be some situations where claims might also flow, say, to the SCN lead entities, so that they can also do data for reporting purposes. But that is generally the process in a nutshell for our claims process. It'll be important to identify in the beginning of the process if an MCO will be using a clearinghouse, because they will be part of the conversation for the implementation. And I'll pass it back to Zach.
All right, great. We can move to the next slide and the next one after that. There we go. So I'm just going to talk a little bit about the roles of the different stakeholders involved here. As we've discussed now a couple of times, Unitas is going to handle the developing the 837P and working with the managed care organizations to follow up with testing and make sure that we're all clear on the process. We'll also kick off SFTP connectivity. Our preference is to host, but we do it both ways with different organizations. with the MCOs, so the role of the MCO here is going to be testing and working with Unite Us, with us on the 837 file, testing specifically. And one thing I want to call out here is that because these are social care claims, it will involve some more testing than probably the MCOs are used to with the medical claims, just from the sense that you all probably handle medical claims all the time. This is a little bit different. This is something we run into with organizations that we work with regularly, that, it kind of seems like it's going to be just like, another day taking another 837 with medical claims, but because it's, a little bit different, it takes a little bit more time. So I just want to set the precedent there, that there may be some significant testing that goes on to ensure that everything works smoothly. And then the other piece I have here is participate in claims implementation calls. One of the hiccups that we run into sometimes with organizations that we work with that we're sending claims to, is that it can take some time to get the right people into the call. Sometimes the process sputters a bit because it's not clear whether the EDI team needs to be involved or other stakeholders internally on the plan side. So making sure that from the MCO perspective that we have the right people on the call will be super important. One other thing to call out here, when we start having those conversations, we don't have the detailed companion guide from the state right now, but we can start right away talking about SFTP connectivity and high-level 837 conversations. And one thing that, Mark referenced the homework that I would love to ask for help on is seeing if any of the MCOs can help get the information from the state about a detailed 837 companion guide. Without that, it's hard for either party here to really get going. So any help you can provide there would be incredible. And now Joe is going to be talking to the next slide.
I have a question.
Sure.
This question from VNS. If would you be willing to work with a third-party administrator if an MCO has one and they have their own clearinghouse to submit claims?
Well, we
Or
work
would
with
they have to pass
clearinghouses.
through an MCO?
We work with clearinghouses pretty regularly. That does increase the effort from a testing standpoint, but we are used to doing that. I just want to be clear that with one additional party in there, the testing does become more complicated, more complex, I should say. Does that answer your question?
Yeah.
Okay, great. All right, Joe.
Sounds good. So I know that there's a lot of small writing through on this slide as well, but this is a kind of an overview of our work plan. And what I want to be able to call out on this particular slide, if you scroll a little bit to the right, I can see there that the MCO and clearinghouse section is now visible. A lot of this stuff that we're going to be working on will be covered on the United side, to be doing the development, making sure that kind of everything is set up. But there will be certain points in the implementation process where we will be leaning on the MCO and clearinghouse for various aspects of the testing, configuration, information flow. When we are waiting, for example, on public keys or waiting on a confirmation of successful connection, that could be the things that delay our testing a bit. But again, all of these aspects in here are kind of building on the already strong infrastructure we already have at Unite Us to be able to generate 837s. This all represents kind of the work to ensure we are able to properly be able to format the 837s, making sure the SFTP connectivity is involved, but it will be a kind of collaborative effort through that. So just kind of another example of how that work will kind of go back and forth between us and the MCOs through that process. And I'll pass it back to Zach.
Okay. All right. So in closing here, we wanted to give you a high level sense here of the 837 implementation process. I know there's probably going to be lots of specific questions related to your organization. We'll be happy to handle those in a one-on-one setting. But happy to answer any questions you have. One more request other than the help with the companion guide is just to reach out to us. Hopefully maybe Mark or Rachel from our team can pass along our email addresses. If you can remember this, it's zachary.parker@unitus.com and Joseph Jablonski or joseph.jablonski@unitus.com. And just let us, thank you, Joe. Can you add Gracious's in there as well? And just let us know the team members who should be involved in conversations to kick things off from your organization so that we can set up times and start those conversations. All right, so any questions?
Is it back to me?
I think so.
All right, you can go to the next slide. So I prepared a couple of thought starter questions here, largely because they're questions on our mind, and I think some of it has already been referenced. So the first question was about obstacles to contract execution, and thank you, Derek and Tina. I think you already kind of mentioned two concerns that you have related to the contract. The state has set a deadline of October 16th, but we wanted to hear if there were any other obstacles that you all foresee in meeting that deadline, because we'd like to be very transparent with the state about, you know, the current status, whether we're on track or not towards meeting their deadline. And I know many of you have reached out for individual conversations, so and have communications underway. I've included the contact on here for those for John Paul Quinn, our senior project director. He's kind of tracking where each MCO is in our process with them. Some of you have requested documentation from us, so kind of multiple steps in getting to that contract. He's kind of keeping track of where we are. Some of you have requested meetings, and he's coordinated that. Please let us know about any obstacles you have towards execution. Another question, we wanted to find out about plan's intention to do screening and navigation as a part of this waiver, and your needs for training or onboarding onto the platform. Have plans discussed this, and have you landed somewhere?
This is Jill. Oh, sorry. Go ahead, Chad.
Sure. Hi, it's Chad from Elder Plan. We've decided not to participate in the screening as a plan, but just to go back to your first bullet point, there are some, I'd say, components in Section D and the MCO responsibilities that are a little vague that we have sought some clarification on related to payment and timing and some of the A and G sections. I'm sure some of the other plans have questions about it as well. I don't know necessarily if it would delay the October 16th, but we're hoping to get some level of clarity based on the vagueness and some concerns we have in that section. So wanted to share that as well.
Chad, we have the same concerns at Health First around A and G. And also, while we're talking about Exhibit D, the member notices date has seemed to change. We have emails from the state saying that it's 30 days from the start of service. But if you look at 1.1A, it's now 30 days prior to December 1, which means notices would have to be mailed out in less than a month from now. I don't know if other plans are planning to send their notices out by November 1, but I think Health First is going to stick to the December 1 original date that we have on email.
We're doing that as well, Derek. The December 1 is what we were planning. And just one other thing, some of the reporting isn't exactly clear about what is required from the plan. I'm sure we're all looking for some clarity on that piece, just to mention that as well. Thank you.
Coordinators are not the same. And Zach, to answer your question, at this time, Health First will not be able to do the screening and social care navigation. So it's something we'll evaluate down the road.
But I do want it to be clear that any plan can refer members to, we have, some of you are long-standing partners, so you know this, but we'll do the screening and navigation process for any member you think who needs it. So please be sure to communicate that with your various navigation teams. Tina?
Same answer as Derek and Chad, Zach.
Another question we have, and this is kind of in our assessment of our technology capabilities and what we might need to enhance as a social care network from our current state. And maybe you can't answer this question without the claims companion guide, but have there been conversations on the plan side about what you're going to do with these $0 claims that you receive and what you think you might be giving us back? Because this is not a traditional claims process, right? In some ways, we are acting as a payer for these services, but we are submitting these $0 claims to the plan. And in a more traditional claims process, we would get information back from you all in the form of 835s, and we would use that information to close the loop on revenue cycle management. So do you have any knowledge, or are there any plans underway, or even ideas about what you might give back to the social care network after we've submitted these $0 claims to you?
Zach, our plan is to return an 835. And when you say submitting $0 claims, the charge amount that's included on the claim, is that going to be essentially the fee schedule of the allowed amount that that is I guess associated with the service?
Yes.
Right. I think on the charges, our system, and I don't know if MCOs, other MCOs might have this issue. If they're actually $0, the claim itself will either reject or deny. So good to know. But yes, the to pay amount when we return the 835 would be $0.
And are there any ideas about reviewing, like, would you be giving us information about we would have paid this, we would not have paid this, or we don't see this person as eligible in a traditional manner?
Yeah, Zach, that's a great question. We actually have a lot of questions around how that's meant to work as well. For example, if a HCPCS code is submitted that has to do with housing instability, then does it have to be accompanied with the appropriate DX codes Does it have to be in primary positions? What happens when there are multiple services listed on a claim? Well, we have a lot of outstanding questions around that. Questions we're bringing to our meeting with the state tomorrow.
So it sounds like having the capability to ingest and process the 835s would be important for revenue cycle management, even with all of these unanswered questions.
Right. And also for, one of the MCO's responsibilities is to do an annual financial reconciliation. I would imagine that the 835s, the adjudication of these claims is going to be very important to that process.
Other thoughts, questions for discussion?
We had some questions earlier on in the chat about how PHS will be doing screening, if it'll be just our staff, if there be subcontracting.
So as I mentioned in our kind of navigator as last resort model, and that is inclusive of screening, is we thought it was really important not to stand up a new siloed navigation workforce as an SCN, but rather leverage the resources in the community, and that includes both healthcare and CBO resources to the greatest extent possible in screening, navigation, and the provision of services. You think about how many Medicaid members are in Queens, Brooklyn, and Manhattan, it wouldn't even be feasible to have one agency handling all of that screening, and certainly not doing it with any kind of quality. So we are going to leverage the resources of our network in screening and navigation. One of the biggest challenges that we foresee is in the fact that the interoperability guidelines have only been established for screening, meaning that with our healthcare provider partners, we can pay those contracted with us to do screening if they meet interoperability requirements. But those have only been established for screenings only. What that means is that the screening may be decoupled from navigation. And you could imagine what that would mean if we contracted with a very large healthcare provider and then kind of were inundated with screenings that needed to be acted on. We all know how challenging engaging members is when you're doing it by phone call. Working the lists, right? It hasn't been our experience that that is the most effective engagement strategy. So we are going to prioritize to the greatest extent possible screening partners who have a plan for navigation, whether that's in our platform. Well, it has to be in our platform in the beginning, but whether the screening itself is happening in an EHR, and the navigators that they employ are working in Unite Us. We hope that there will be further progress on the interoperability required for the other components beyond screening. But it's certainly not there yet. But to return to the original question, yes, we plan to use our both healthcare and CBO partners to the greatest extent possible in completing the screenings of Medicaid members.
Hi, it's Chad from Elder Plan again. I have a couple of questions. One, in terms of the contract, because I know we've raised some current issues and realizing our timeline is super tight. Is it your understanding from DOH this is final? There will be no further changes. And then secondly, which you'll probably talk about towards the end, but wanted to raise it. What are your next steps in terms of coordinating with all the plans for SC and go live?
So we do think that this is the last version of the contract that will be released. However, it sounds like many of you have questions that you've put forward to the state for clarification. And so we cannot say for sure that they won't drop another version. We're going to act as if this is the last version in terms of coordinating with you all towards execution. And our plans for that are, some of you have requested meetings with us prior to execution. We'll do our best to honor that. Others of you have not. We are taking a look at the versions that have been submitted to us because some of them have been modified by you, and we don't know if those modifications are permitted. So if you haven't gotten approval for modifications and you're sending us a contract, please be sure to tell us that you have altered this contract. And it's really up to you to have those modifications or changes approved. We cannot speak to your reasons for the changes that you may have made to this contract to the state. Like, we just don't know the business sufficiently. And so, yes, send us the state's version or assure us that they have approved your version. And then our quarterback for all of this is John Paul Quinn. His contact is here. Please direct kind of questions and answers there so we can coordinate effectively.
So we're clear that you want us to initiate signatures into you for you to then execute. Didn't know which way that was going to flow first.
If you're comfortable executing on your side first, we will we can handle that workflow. If you want to have a conversation first or you want us to execute first, we can handle that workflow as well.
Hey, another quick question on claims. So would you submit claims at a set frequency to the MCOs, or would those claims come in as and when the service is surrendered?
Unitas, you want to take that one?
Yeah, I can take that. Our standard procedure that we stick to is sending daily claims files. I'm not 100% sure on the volume expected here, but we typically see
Okay.
there being records every day. So,
Because I believe the directive from the state is to submit, our capitation claims for a PMPM payment, and then we there's a portion of the admin fee, and then we pass the rest to the SCNs. So I think we're going to have to state on the webinar, but we're still not clear, because if we submit a claim, a capitation claim to the state on the 1st of the month, could take up to 2 cycles. Let's say 15th is when we receive a payment. And how do we pay the daily claims that come through that window? How do we hold back on the 3% fee that the state mentioned during the webinar? How do we configure those rules? I think that's still unclear.
If that was a question for me, I don't know the
Well,
that
I
sounds like a
think
question for the
I
state.
don't have the
Must be
answer
here.
to that, but we have also raised a similar concern about because we have to pay out for services, right? So we
Yeah, you
require
cannot obviously wait for 2 or 3 weeks from the
right,
yeah.
right. So we have asked how quickly the plans can receive the PMPM and how quickly we can receive it in
Yeah.
order to be able
What
to
I've read was it could take up to 2 cycles. That means 2 weeks from the day that we submit the capitation claim.
And can you submit that in advance of the
Yeah, I believe one of the directive from the webinar was, submit around the 1st of each month. And it could take up to 2 weeks for the MCO to receive the PMPM.
Thanks, that's helpful. Other questions, Ralitza, in the chat?
Yeah, we got one just now. Any information or guidance on if or how SDNs need to be credentialed by MCOs?
I'm not the right person to answer that question. So I'm going to have to see if there are other knowledgeable MCO counterparts on the call that could address that. Feel comfortable answering.
We'll bring it up to the state tomorrow.
Thanks, Derek.
No problem. We need a much longer meeting with the state. A lot of questions. And Zach, to your earlier point about modifications or red lines to the template contract, our understanding, and I suspect other MCOs are probably operating under the same understanding, that the template that we received from the state is a template that is modifiable. And we'll find out tomorrow if we're required to, hopefully we'll find out tomorrow if we're required to get approval for any modifications first. But I suspect like every MCO, every other MCO will have, some kind of red lines to go along with the template that we send to our SCN partners.
Yeah, it's very challenging because we don't know how to respond to your red lines. Like we don't know if what changes you have proposed are acceptable to the state. And in some cases, the changes look like they don't augment the overall nature of the contract, but in other cases, what we've received looks very different what the state put forward. So that presents much more of a challenge about if we can execute.
Yep. No, fair point.
And I think the only other question in the chat was a question around when fee schedules are slated to be released, as MCOs are unable to complete system setups without. Is it Unitas and PHS's understanding that the fee schedule is meant to be presented as the allowed amount when adjudicating the claim?
That is our understanding, and we have received a sort of fee schedule template that we were asked to provide some costs and some cost information and some commentary. We have provided that back to the state, and most of what we were working with were ranges that we would pay for the various items on the fee schedule. But in our last conversation with the state, they asked us, we discussed the ranges in greater detail, and they asked us to come in at a specific dollar amount. And so we anticipate that there will be specific dollar amounts as opposed to ranges on the final fee schedule. But I will also say that we do not anticipate the fee schedule to be the same across the state. So each SCN's fee schedule might have different dollar amounts that they have had approved by New York State. And so that's the best I can answer that question.
Yep. Zach, does PHS's fee schedule differ between the counties that you guys cover?
No.
Okay. That's helpful because that could be very challenging to load.
There are, granularities. So, providing a halal meal is not the same price as providing a regular meal. So there are different dollar amounts for those different tiers, by way of just one example. But we are landing on specific dollar amounts, and they will be the same across our region.
Thanks, Zach. That's helpful.
Another question came in asking if the social care plans will be available to the MCOs.
So what the plan is really, and maybe Unite Us can speak to this in a little bit more detail, but everything that's in the social care plan that's required by the state as a social care plan has been encoded. And so it should be available to the plans as a part of the billable service. In that regard, it differs from what you would typically think of as a care plan, because it's really eligibility and referral information in the form of codes. Unite Us, did I articulate that according to your understanding of what a care plan will contain?
I'm not sure I understood the question, to be honest with you.
I think the state has said that they require care plans for navigation and for enhanced care management. And but when you dig into it, it's not a traditional care plan. It really is the eligibility assessment data and the referral information and the outcomes of those referrals, all in the form of coding that I believe is specified and will be a part of the billable service, as opposed to, here's a written care plan with narrative about a person's circumstances, which you think of when you would think of a traditional EHR-based care plan. That makes sense to folks.
Okay. I don't know the answer to that right now. We can take that back and find out though.
But just to expand on that, I think what we were probably looking to, will there be like an account manager assigned to each managed care organization? And how will the communication bridge the gaps with the MCOs?
On the Unite Us side, is there an account manager, or are you asking about on the SCN side?
The SCN side.
I don't think we have that as their title, but we will have account managers within our finance department.
Just to go back to the care plans, I think from a, care coordination standpoint and clinical standpoint for the MCOs, it helps to understand what's going on with the member, and the codes will help maybe guide to say they received food services or something. But just understanding, sometimes the complexity of what's going on with the member, it is helpful to have. And I don't know if that's required or what is required. I know that the requirement for the navigator, I believe, is to develop a social care plan. But I'm just thinking from a clinical standpoint, the value of this to the MCOs and their teams in terms of care coordination. And the other question is, when you send those codes, will the MCO be able to see who has provided these services? So you will see the agencies providing this, the community-based organizations. Okay, thank you.
Yes.
Another question was how many licenses to the Unitas platform will be distributed to each plan? I think that means users.
I don't know the answer to that one. We can take it back. Our team handles the claims delivery component. So that's not something that I'm totally familiar with, but I'm happy to try and find out the answer to.
And what I can relay is what the social care network is responsible for, and what our contract with Unitas covers is for organizations contracted with us, contracted member organizations. So those are our CBO. Our CBO network partners are all covered with the licenses that they need as a part of our contract with Unitas. That the operations manual does not describe plans in the same way when it comes to the SCN. The SCN is not required to provide outside its network members licenses. So if you're interested in being on the Unitas platform, please do let us know so we can have those conversations and make sure the needs are met. Are those all the questions, Ralitza? All right, well, I think this has been a great conversation. I think we learned a lot from hearing the types of questions that are on your mind, both in terms of what we need to do to support you in the partnership, the questions that we still have related to the contract. And also, I think we came away with a better understanding of the claims process that we can anticipate both through our technology partner and from hearing about some of your plans for what to do with these claims. So again, please don't hesitate to reach out as we move towards contract execution. We will be talking to the state about what to do with revised contracts that we're receiving. And if you are one of those plans that made changes and submitted those to us. We will get back to you quickly on whether those changes are acceptable. In the meantime, again, the contact here for the contracting process is John Paul, who's managing kind of all of the communications, follow-ups, and our own submissions to you with the required documents that you've requested of us. And with that, I'll say thank you for your time. We're really excited about what this opportunity means. I didn't say it earlier, but having had a look at the fee schedule, I would be remiss in not saying to you all that it's clear CMS has learned about how to narrow in on the populations that are most impacted in addressing these needs. So there are a lot of eligibility criteria to receiving these services, but once you are eligible for a service, the benefits are really quite, in some cases, are really quite meaningful and substantive. So we're really excited about a lot of things in here, like the ability to cover back utility bills, the ability to make critical home modifications, to provide expanded access to medically tailored meals. These benefits are quite meaningful and quite impactful. And so I hope that as we proceed together with this collaboration, we are always keeping in the forefront of our minds the potential for that these new resources hold for really helping people, enabling people to put and keep their health first. So have a wonderful day, and we will be in touch with all of you soon.
Thank you.
Thanks.